I'm Ed Nersessian. Francis Levy and I are co-directors, and Francis Levy is away this week. Tomorrow we have a program that starts at 2:30 also called Moving and Playing Jazz Improvisation and Dance Conversation. That will be a discussion with music and with dance. Jane Ira Bloom, who has been here many times, is moderating that. Carmen de Lavalade, Rufus Reed, Aaron Schaefer-Heiss, and Andrea Weber are the participants. And then next week we have a program called The Allure of the Hive, Social Networking and Social Change, which is about Facebook and all the other networking programs. And David Kirkpatrick is moderating that. He's just written a book on Facebook. Today's roundtable is called Understanding the Placebo Effect. And I will introduce Rob DeRubeis, and he will then introduce the other panelists, and then we can get going. He is the Samuel H. Preston Term Chair in the Social Sciences and Professor of Psychology at University of Pennsylvania. He conducts research on placebo and has written extensively on it, both in terms of the positive and the problems with research pertaining to placebo.
Thank you, Ed, and it's my pleasure to be here. This is new to me. This looks like a wonderful series of events, and we'll try to make this one in the series of wonderful events. So, first introduced to Robert Ader. I first learned of Dr. Ader's work when a colleague of mine touted it and pointed me to it many years ago. It's Alan Fridland. You may know Alan, and he's been at the he's been a distinguished and is a distinguished university professor at the University of Rochester School of Medicine and Dentistry, and is past president of numerous societies, and was one of the founders of the field of psychoneuroimmunology, the field that looks at the connections between mental events, environmental events that might trigger those, and the effects on the body, in particular on the immune system. It's a fascinating sub-area, if you will, of psychosomatics, a field that he is a world expert in. We have, to my left, John Kelley. John recently wrote a fascinating paper that looks at the placebo effect. This appeared in Scientific American. He's an assistant professor of psychology and statistics at Endicott College and an instructor of psychology at Harvard Medical School. And he investigates the placebo effect in medical and psychiatric disorders. And to John's left is Rosamond Rhodes, who's a philosopher and professor of medical education and director of bioethics education at Mount Sinai School of Medicine, and a professor of philosophy at the Grad Center at CUNY, and also professor of bioethics and associate director of the Union Mount Sinai bioethics program. She's written extensively on bioethics issues, including a book, Physician-Assisted Suicide, Expanding the Debate. And Richard Kradin, across from me, is a medical internist and psychoanalyst at Mass General in Boston and associate professor at Harvard. He has served as the research director for the Mind Body Medical Institute in Boston, and has received numerous prizes, including the Upjohn Prize for Cancer Research. And among his at least 200 articles by count, and 4 textbooks, including the one that's, I suppose, most relevant today, The Placebo Response and the Power of Unconscious Healing. So, thanks, Ed. Okay. So, when I was approached about the possibility of coming here and discussing the placebo effect, it was in the wake of a paper that my colleagues and I published that examined the relation of the antidepressant medication effects to placebo effects in people with depressive disorder. And I'll just start this off briefly, but what my colleagues and I examined, this is a paper that appeared in the Journal of American Medical Association, was looking at the effects, the comparative effects of antidepressant medication, placebo, in mild and moderately depressed outpatients. And this was a group that had not been looked at closely before and not been published on before. Why? Because it was understood that the placebo effect is quite powerful in depression, and that in order to obtain consistent and strong effects showing antidepressant medications superiority to placebo, one needed to treat and study people with relatively severe depressions. So this brought up certainly in the press, and my colleagues and I were questioned about it quite a bit as to how do we understand all of this. We know that antidepressants, people use them, people, how to put it, value them, even when they're not among the more severely depressed patients. And so the question is, does this mean that antidepressants don't work for that group? And of course the answer was no, that wasn't what the research showed at all. It was that they don't work demonstrably better than this thing that we know about and don't know as much as we'd like to know about, namely the placebo effect. And so I was eager to come up here to discuss with all of you what it is that we know about the placebo response. I have some ideas, but there are others on this who've looked at this quite extensively and can tell us what is known or what is being researched now, or how we can think about how something in a pill, but provided by a doctor, can have powerful effects on not just psychological functioning, but on the physical correlates of that, or the physical sequelae of that. So I want to open it up to perhaps Dr. Ader or anyone on the panel to begin to introduce us to how we can think about this, how we can think about the placebo.
Our research and our approach to the whole problem of what is a placebo is so different from anything that's currently going on that, in contrast, I prefer to go last rather than first.
Okay. John, yes.
I guess I've been thinking about what I might start by saying. Well, first I just want to thank Ed for inviting me here, and I'm really delighted to be here with a very distinguished group of people. I noticed that everybody's first name begins with R except me, so I'm not sure what that means. But anyway, but I was thinking about this, and the placebo effect, if you think about it, is an oxymoron. The placebo is a treatment that has no effect. So the placebo effect is the effect of a treatment that has no effect. So already we have a problem. And people have written about this, and I think once you start to deconstruct the placebo effect, you start looking at some particular things, like the hope that the patient might get by receiving some sort of treatment, or the therapeutic alliance between the physician or whoever the treater is and the patient. This is healing in and of itself. And all of a sudden, we're not really talking about placebo effects. We're talking about what sometimes people call non-specific effects. And indeed, those very same effects that make the placebo effect occur happen with real treatments. In real treatments, I think it's true as well that the very same treatment, if it's given by a physician or a treater who is more empathic or exudes more confidence or somehow is matched to the patient, you're going to get better outcomes than otherwise. So I think that what we're talking about, there's a problem with the word right from the beginning, placebo effect. But so sometimes people talk about non-specific effects. In psychotherapy, they talk about common factors that are common to all kinds of psychotherapy, and that may be common really to medical treatment.
I started out my career and continued to practice in internal medicine, but then went on to train in psychotherapy and psychoanalysis. And one of the things I recognized was that in my medical practice, there were many patients who had essentially problems that we could find no objective cause for in our testing. And that in my psychoanalytical practice, I was seeing patients who had somatizing issues that were very similar to what I was seeing in my medical practice. So very clearly, we're talking about an area of mind-body interaction here. I would second your thought about the issue around terminology. I try to make the distinction in my papers, in my book, about placebo effects versus placebo responses, because I think placebo effects are what you see when you give what is thought to be an inert medication. The placebo response is whatever is going on endogenously that produces these salutary effects. And those salutary effects, I think, overlap in very substantial ways with some of the basic elements that psychotherapists know from their practice. As you mentioned, empathy, attentiveness, producing a state of mind based on expectation, hope, faith, whatever terminology you use, which overlaps and is difficult at times to sort out. But the elements are very similar. And on the reverse side, there's something also very similar, which is the so-called nocebo effect, where you see patients who respond in negative ways to the administration either of a so-called active drug or to a placebo. And you see patients in therapy practices, these so-called negative therapeutic reactions, where anytime you offer help, you get a similar sort of negative response. So I think there's, and I've gone into it in some of my writings, but I think there is an overlap there. And I think there is some common mechanism underlying both of these responses. Unfortunately, it just hasn't received the degree of scientific attention that it really deserves.
It's interesting what you just said about nocebo effects, because I think also often it happens because of expectations. The patient is told, well, for this active drug, here's what the side effects might be, and if it's a randomized controlled trial and they're getting a placebo, they then exhibit often the very same side effect profile as what you would see with the active medication. So at least part of it is kind of an expectation. Here's what I expect might happen: dry mouth, blurry vision, or whatever.
Right. And we have an ethicist on the panel. And it becomes an ethical issue because we're mandated at this point, when we give a medication to a patient, to go through the entire list of possible side effects. Well, some people are very sensitive to that, and it will induce many of the side effects that you list, but to not go through that list raises ethical issues.
Well, ironically, it's an ethical issue that you raise them too, because you are inducing potentially negative effects in the patient by raising these possible side effects. So you're damned if you do, and you're damned if you don't, in some way.
Could we go back to the definition? Because I'd like to go back to the definition of what is a placebo and what is a placebo effect, and question it on the grounds that a direction was set centuries ago, and it was the wrong direction. The word was wrong, but I don't want to go back that far in history. But what I want to question is a fairly typical response, which is that the placebo is neutral, that it has no therapeutic effect. Well, maybe the first time it's presented, that's true, but not after that. That it's a non-specific response. Well, maybe the first time it might be non-specific based on an experiential history about which we know nothing. But there's nobody on this planet who has not been helped by somebody for something at some time. And so the first time somebody is given a placebo, in quotes, there is a generalized non-specific response. But that changes in the course of chronic treatment. 90% of placebo research has been on the acute effects of placebo, not the chronic effects. And the worst definitions, of course, are those that contain within them the explanation of the phenomena. So the placebo has this therapeutic effect based on the expectancies of the patient. Well, we don't have to do anything anymore. You've already defined it and explained it in one sentence. There are alternatives. Expectancies, which, by the way, are real and effective, as the nature of the physician-patient relationship, as the size of a pill, as the color of a pill, etc., are all real variables that influence the magnitude of the response. But it's all the acute response. Under chronic conditions, a placebo, if you adopt a learning model, and expectancy is a learned response. I mean, where does an expectancy come from if not from experience? Under those conditions, I think that there is no explanation of the placebo effect, because there are lots of placebo effects under lots of different circumstances. And part of those placebo effects are due to learning. They're conditioned responses. And within this context, a placebo is neutral only the first time it's presented. Once it has been paired with an unconditioned stimulus, some therapeutic agent that does have primary and secondary effects. And by the way, drugs don't have primary and secondary effects. Experimenters have primary and secondary effects. Whatever you're interested in is a primary effect. Whatever you're not interested in is a side effect. The drug does whatever the drug does. But once it's been paired with this therapeutic agent, this unconditioned stimulus, it is no longer neutral. And so you can use this in ways that are called for by everybody who's working in this field. How are we going to use this clinically? Well, knowing that the size of the pill and the color of the pill, that's all very interesting. But it doesn't help you in a clinical situation particularly. If you, all drug studies, essentially every drug study that's ever been done, involves only two groups. One group gets the drug and one group doesn't. One group goes through all the procedures and is reinforced or rewarded by the therapeutic action of some agent. The control group, the placebo group, goes through the same behaviors and is never reinforced because there are no therapeutic effects. So in behavioral terms, the drug group is on a continuous or 100% reinforcement schedule, because every time they engage in this behavior, it's reinforced by the agent. The placebo group is on a 0% reinforcement schedule, because it goes through the same behaviors and is never reinforced.
But so would you say that the pairing of my satisfaction, so I take a placebo today, I don't know it's a placebo, I'm in a study, and I take a placebo today, I get up tomorrow morning and I think, oh, this day's looking a bit better. This is really good. I'm glad I'm participating in that study. Wouldn't it, by the logic that, as I'm understanding it, wouldn't that then be paired with the taking of a placebo? Wouldn't that then help me the next day? All else equal, of course. I mean, I may wake up the following day and get a cold water thrown in my face about the whole matter. But at least in the first instance, I've now associated the taking of this pill with a wonderful thing. Now, what very often happens, I think, when people engage in this kind of, in this series, is that they then, now feeling better today, I think I will go out and ride my bike, which I haven't done in a while, because I am feeling better after all, and I am getting better. And of course, these things would then have self-reinforcing properties. And although I think it's correct, as far as we know it, as far as with the research, that the longer you run a placebo trial, the less and less potent it looks. At least for several rounds, it's one can at least construct a story in which the placebo is having these effects that are, in some sense, quite palpable.
Yes, and within a learning model, one can test some of these because you're now talking about its resistance to extinction, and unless that placebo receives some reinforcement,
right,
then it's not going to last. Now, it gets back to some reinforcement. If your treatment group is on a 100% reinforcement schedule, and your placebo group is on a 0% reinforcement schedule, then what happened to all the reinforcement schedules in between? You could treat patients with a 50% reinforcement schedule, meaning only half the time is the, quote, placebo reinforced by the action of the drug. Now, if you can approximate the therapeutic effects of a full-dose regimen of drug by capitalizing on conditioned pharmacotherapeutic responses, a 10% reduction would amount to several millions and millions of dollars a year.
But how would you know that that reduction in the agent was attributed to the placebo effect rather than some other physiological, biological effect?
It is due to the biological effect because what happens is that as you continue to present conditioned stimuli, I call them conditioned stimuli rather than placebos because I'm not wedded to a change in the whole definition, et cetera. I'm concerned with conditioned pharmacotherapeutic effects. So I don't have to use that language. But it is based on the biologic action of that conditioned stimulus, which will repeat in kind, not exactly the same as the unconditioned stimulus, but will approximate the unconditioned stimulus, unconditioned response.
Another kind of question. So when drug companies go to test their product, they're looking for, like phase 1 studies, they're looking for the level at which you don't get very dramatic, terrible side effects. And that's how they set their dose of the drug. Now, then they give it in phase 2, phase 3, now it's on the market, and you're giving the whole dose. Nobody's tested how much of the dose is necessary to get the desired effect. So if you're trying to alleviate depression and you think you need a whole big fat pill to alleviate the depression, and then I'm testing to see if somebody has learned to respond because it's a big fat pill, I give them half. Maybe half was all you needed to get the response.
Yes, that's a good question, and it has come up in a paper we just published. This is not all fantasy that I'm talking about. We've actually done this with
No, I can believe that you've done
patients.
it, I'm trying to sort out how you know that it has anything to do with the placebo effect rather than a pharmacological effect.
Two additional groups are in these studies. One group receives drug all the time, but if the experimental group is on a 50% reinforcement schedule, then that group is on a 50% of the concentration. And the other group that's added into such a study is a group that doesn't get a specific placebo at all, but is treated with drug on the same schedule as the partial reinforcement group. So they're getting the same amount. They're getting the same amount, but less frequently.
Got it.
And the other group is getting it all the time, but only a reduction in the concentration. So if we, this is a good question ethically. If we say to patients, during the course of this study, we are at some point, or we may at some point, reduce the amount of drug that you get. Now, that's perfectly accurate, but is it enough? Because the assumption will be you've reduced the concentration. I don't know anybody who's come up with the answer, you can reduce the frequency. And we're reducing the frequency, not the concentration.
You know, when I first started researching placebo responses, it led me to something which I found to be perhaps much more interesting and perhaps much more disturbing. And that is how we actually determine what's therapeutic. And I think when you begin to look at the criteria that we use to determine what is actually causal in terms of a therapeutic response, many things begin to come apart. So for instance, I mean, we didn't talk about placebo responses until we were at the point in medical scientific development to look at what we thought were treatments that were truly active and specific. It was only at that point that all the treatment that came before became potentially placebo. So that currently, you know, the way we essentially define placebo is in the context of an operational clinical trial as that group that is not getting the active intervention. The problem there is not only questions related to dose and frequency and the like, but you know, I just came back from a course in London related to tropical diseases. And one of the facts which has come out recently is the same treatment for malaria works in South Asia and doesn't work in Africa. And in all of the clinical trials that we do, they're complicated, they're almost impossible to reproduce. And we use that information and we generalize it so that virtually every time a physician prescribes a medication, he's prescribing it outside of the context of what we would call a controlled clinical situation. And so everything becomes potentially placebo.
Well, I think
because you don't have that degree of reproducibility in clinical trials.
Well, so let me ask this. So you mentioned tropical diseases, and you know, we talked a bit about depression. Those of you who've been looking at placebo responses for years in your research, what would, just for all of us, if you could give an example of the most impressive demonstration of a placebo response or placebo effect, or groups of individuals getting better from some pretty bad things by taking what we think is an inert substance?
I think the most impressive examples are the ones that come in surgery, the so-called placebo surgeries. So there was a procedure called the Weinberg procedure that was done back in the late 60s, early 70s for people who had angina, where they did a coronary revascularization. It seemed very obvious because it was very plausible that that procedure was going to relieve anginal pain, until someone decided to do the so-called sham surgery, which was they opened up the chest, they didn't do the revascularization, they closed it back up, and those patients did just as well. We've had a recent example of arthroscopic knee surgery with patients who have arthritis and joint mice removed by arthroscopic surgery, sham surgery done, anesthetize the skin, make a cut, close it up, same response in terms of pain alleviation. So what's
the mechanism of that? What do we think about how this, those that, you know, those people who study these things, they have to have tried to pin down what's going on there.
Well, in those studies, they're not studying the placebo effect. They're using the placebo effect as the control to find out if the intervention's effective or not. So the one that's been most notorious in the bioethics literature is a Mount Sinai study of sham surgery to test the efficacy of fetal brain tissue implants into the brain as a treatment for very serious Parkinson's disease. And while it sounded good, our neurosurgeon correctly thought, well, how could I possibly be justified in applying this intervention, people will call it treatment, without knowing if it works, even though it sounds really good. So he devised a placebo study where he matched the people so they're all very, very ill and similar. And some of the people got a burr hole in the brain and fetal tissue implant into the brain, and other people just got a little hole, never piercing into the brain. And they all had to take immunosuppressive medications. And then we waited and saw what happened. Who got better and how much better? And what he learned was that the people who got the fetal brain tissue implants got no appreciable benefit from it. And in fact, if you were over 60, you got no benefit at all. It did not work. If you were under 60, you got some benefit. The remarkable thing that I think says something about placebo effect is people in the sham surgery group who got just the little burr hole. I'm sorry, I left out a part. Before the surgery, everybody was told you'll be in one of these groups, and if the procedure is effective and you were in the placebo group, you will get the treatment. So there were people over 60 who had been in the sham surgery group who were very upset that they weren't being given the intervention that was shown not to work. That's an example of the placebo effect. So if you think a big pill is more potent than a little one, and maybe a blue one more potent than a yellow one, surgery is certainly, because of the expectations and whatever goes into placebo effect, has a very powerful placebo effect, and neurosurgery has to have the biggest effect of all. So it was kind of shocking. The ethical point is almost all bioethicists think that this was a horrible, horrible study, because how could you make a little hole that doesn't go into the brain and put people on immunosuppression for 6 months? So they said, harm them without providing any direct benefit. Now, if I ask you to think about it for a minute, which of these two groups were exposed to the greatest risk and harm? Clearly, the active group. They had this foreign matter put into their brain. So the bioethicists, not me, but the other bioethicists, all thought that this was really terrible because they thought the group that was significantly put at risk and harm were the placebo group. And this is backwards thinking. But I think the important issue is that it shows whether a treatment is effective or not. So or an intervention is effective or not, then if it's not effective, nobody should use it. So you don't have tens of thousands of people getting this arthroscopic surgery for arthritis in the knee that has never been tested because it's believed to help people when in fact it does no good at all. So I think placebo in showing the efficacy of an intervention is critical.
To go back to that particular study, the osteoarthritis of the knee study, and your question about mechanism, and I mean, one of the problems, I think, in that kind of study is that we see that the people who had the sham surgery did very well. The people who had the real surgery didn't do any better, but both groups got better, substantially better. But the question is open whether anybody really changed at all compared to what would have happened if you did nothing. So in a way, what you need is a placebo for the placebo. And which is basically natural history or some sort of waiting list. What happens over time for people? Because we just know for many problems, when people present to have treatment, they're often at their worst. When you finally say, yep, I'm going to go and get the knee surgery, things might be particularly bad. I've actually had 2 knee surgeries, and recently, about 5 years ago, considered actually going and having a surgery not dissimilar to this one. and I didn't know about this research. The surgeon said, well, you should go and do some physical therapy first, and in 6 months or something, I was much better. But I was ready. I was convinced. I was having trouble walking. I was convinced I would need this surgery. And yet it turned out, and maybe even if I didn't do the physical therapy, who knows? Maybe I would have been better no matter what. It's hard to know.
Well, on any given day, it's been shown, demonstrated that probably in excess of 70% of people have some sort of physical symptom that comes and goes. And Oliver Wendell Holmes made the point back in the 19th century that people just generally tend to attribute the most recent intervention in time with their feeling better as the cause of their feeling better. And again, I think it speaks to the profound difficulties when you really begin to delve into it as to what constitutes a therapeutic intervention. It becomes very difficult to sort it out. One of the things that I found interesting about the placebo is the idea of perhaps beginning to break down placebo responses at least into two major categories. And one is the psychological effect of feeling better, which I think is across the board a sine qua non for placebo responses. The other is the multitude of different physical symptoms that seem to get better as a result of placebo interventions. And I think one of the profound questions in placebo research is how conceivably can you get an integrated mechanism, rather than a multitude of deconstructing a multitude of different mechanisms to explain placebo responses. Might there be some one integral mechanism that could explain what's going on both psychologically and for the host of physical symptoms that we see or think seem to be responding to these placebos?
I would doubt that very much unless you break it down into those responses that are called subjective, non-quantifiable, all the pejorative words you can think of, compared to hormonal responses or what have you. And there's some literature that indicates that expectancy rules when it comes to the subjective responses, but when it comes to the biologic responses, it's conditioning. Now, if it is conditioning, then it becomes specific to the unconditioned stimulus, and therefore there can't be any single mechanism for it because it depends upon what responses are induced by the unconditioned stimulus, and those are what are reproduced. When they do these brain scan studies nowadays, I mean, this is really amazing. And what they find is that the same parts of the brain light up in response to a placebo as opposed to the regular medication. Now, what they haven't done, and it would be a severe test, but it would be a fair test, I think, of my own hypotheses, would be they haven't measured the brain changes the first time you give a placebo versus the nth time you gave a placebo. Because I would have to predict that there will be no relationship between the two the first time you give a placebo.
Well,
but by the time they've been conditioned over and over and over, that the brain changes evolve as a function of the conditioning.
But there is one thing I think that most individuals, by the time they reach adulthood at least, are conditioned to, and that is the interaction, the dyadic interaction with the caregiver. And that
agree.
may be
that I consider a learning part of a learning process, like the expectations are learned as well.
If I can jump in about this mechanism idea, we did a study recently in irritable bowel syndrome using placebo acupuncture, so a kind of acupuncture that the needle feels like it's entering the skin and you feel the pinprick, but the needle retracts back up inside the housing. So we're treating people who are naive to acupuncture that never had it before. And we had 3 groups. One group was the placebo, the control for the placebo. There was a wait list group. They did receive some interaction with study staff because they had to be measured at the same time points. The second group received this placebo acupuncture from what we call the limited condition, where the person who did the acupuncturist who did the intervention was very neutral, businesslike, and did not interact very much at all. And the third condition, what we called augmented or enhanced, where the practitioner did something like you would probably see in a real acupuncture treatment session, where the acupuncturist does talk to you, and there's quite a bit of interaction, a warm, empathic kind of thing, the common factors again. And we got a very nice, everybody got better to some degree. Everyone, pre-post, there were improvements. So doing nothing, apparently people did seem to get better. Although you could say maybe it's not exactly nothing. They were in a study, they're on a wait list, they might get a treatment eventually, so maybe that had some effect. But nevertheless, we showed that the limited condition is a little bit better. Just the acupuncture with minimal practitioner interaction is significantly better than the wait list. And then the next group, where you get the acupuncture, placebo acupuncture, plus the warm, fuzzy kind of relationship, better still. You get this nice...
and then the full acupuncture.
Yes, we did actually do the, yeah. In this study, in the part that I'm talking about, that was not in there, yeah.
Right, so what happens to these individuals who are getting, how can we think about how people get better? I mean, we're all of us are concerned about various ailments or ways in which we can improve or feel better, and here we have all these wonderful and very often expensive treatments. But what you're talking about is something that wouldn't necessarily wouldn't necessarily have side effects, wouldn't necessarily be expensive. So how do we capture those mechanisms in this was a study of pain?
This was irritable bowel syndrome,
irritable
pain
bowel.
and
Yes,
distension. And,
So how do we capture that to those of us who have trouble with those kinds of things to improve in that area?
Well, the good communication, we try to capture it in medical school by teaching our students to communicate well, to do active listening, to be empathic, to give feedback. Well, this study showed that it worked.
I think he meant medical education.
I think he meant the education,
Right.
yes,
Education
yes.
does.
It works sometimes, yes.
Oh, for teachers, we have to believe it works.
Yeah.
Maybe it's the placebo effect, but we have to believe it.
Well, I think this is where there's a tremendous overlap with what we're learning about the neurobiology of development. There is almost certainly certain both neurotransmitters and structures in the brain that are involved in the learning, the conditioning of well-being for most individuals. We know that there are certain neurotransmitters such as dopamine. We know there are certain pleasure reward centers that are involved. And so the idea of a benign superego, as Sandler used to write about in the psychoanalytical literature, or the idea of the development of neurobiological well-being, I think speaks to what we're talking about in placebo responses. And that's why I think it's rather interesting that when you look at the PET scan data that's been performed in patients who have received antidepressants or in patients who have received the implants for Parkinson's disease, where there is an increase in dopamine levels in the brain, that some of these structures are the same structures that are involved in what has been termed the development of salutogenesis. And so the question is whether placebo responses are specific. In other words, when you look at the biology of what's going on inside the black box, as we're now beginning to be able to, whether these placebo responses do induce a certain set of activation structures within the brain, a certain set of neurotransmitters that largely mimic what's produced during development as we develop our own underlying sense historically of well-being.
Well, are those specific responses, or are they generalized responses? Are they common to all placebo effects, which doesn't mean that they are the cause of the placebo effects. It just means that whatever benefits derive from this also affects these particular brain structures.
Yeah, I don't think we have enough studies yet, but
No.
I think in the few that have been done, they seem to involve similar structures around the nucleus accumbens, those areas of the brain that are involved in so-called reward centers, although it's an outdated term.
Yeah, it's a big step to generalize from the few studies that have been done,
Sure.
though, to any placebo effect is going to do this.
No, it's true. But I think one of the things we're also learning from scanning is that much of what we see when we scan the brain really just supports what we already largely know by the subjective reports of individuals. So if they tell you that they are feeling better, then we need to understand what is the underlying neurobiology of well-being. And I think that's where we need to be directing these placebo studies more.
I would guess that it's more than just what goes on in the head. We know, for example, in genetics, now people talk about epigenetic effects. Mm-hmm. So environment can actually change your genes. You talked about learning and conditioning. Why does all the learning and conditioning only happen to the brain? Why isn't it more generalizable? Impacts on the immune system, impacts on your biology, maybe even on your microbiome. So I would imagine when you're talking about the placebo effect that it's much more diffuse.
I think that's almost absolutely true. I'm sure you would agree with that. I mean, the entire system, whether it's the nervous system, the immune system, the endocrine system, is largely conditioned, and it's conditioned towards certain pathways. And so I think one of the ways of explaining this placebo response is to see that there may be some superordinate pathway that gets, activated almost in the mathematical terms of what, some mathematicians call attractors, that really subserve the behavior of a whole variety of systems which are integrated.
So what that would, what that would suggest is that if we were giving someone a placebo for, let's say, depression, we would expect that if there were other problems, perhaps a knee, perhaps an irritable bowel, perhaps other maladies, that if we kept track of those, that there would be positive effects there too. So that would be a different mechanism than the one that says, I'm taking this pill for my depression, whatever mechanisms are mobilized help with the depression and in a focal kind of way, whether it's through learning mechanisms, whether it's expectations. But the other way of thinking about it is that when we are engaged in some kind of treatment, we are engaging an array of mechanisms that would then have benefits throughout whatever systems are not up to speed.
I would guess it would probably work better if you'd say, I'm giving you this for your depression. It may also help your irritable bowel or your psoriasis or something else. Mm-hmm, mm-hmm. It might help both.
I mean, part of the problem is the science that we currently use, and it's understandable. I was raised in that science, and very few, I think, people in the medical world know how to apply any other type of science. But I think the science that we use for a system of the complexity of the body and the brain is not the science that really is applicable. We're still looking at causal reductive scientific mechanisms. We're going to do A and look at the result in B, and you've got enormous complexity that we don't know how to address. And that's another area that really needs to be looked at. We need to find a different way of looking at complex systems. They may not be predictable in quite the way we would like them to be, but at least we might get some sense of the directionality, the trajectory of these systems. We don't have it.
And it's the old argument between classic reductionistic strategies and the interaction or integrative functions that really exist. Mm-hmm. It's too difficult.
Right.
And I'm sure everybody knows about the drunk who's walking around the lamppost looking for a key. And somebody comes along and says, well, I'll help you look for the key. They can't find it. And he says, well, are you sure you lost it here? No, I lost it down the alley. What? The light's better.
Right, exactly.
So, and that's the way that science is done. The light's better. And so we're looking for a magic bullet, a single cause, a single effect. And it's never going to happen.
Right.
But it sounds to me like that isn't actually what you're looking for when you do a randomized controlled placebo study. You're trying to see if this thing that you think is a cause is in fact a cause, not that it's the only cause. So if it doesn't work, then you learn that it's not a cause. And that's all you can claim.
This is a good example of the fact that we're talking about different responses. Yes, there are times when a placebo is used to test the efficacy of a drug. there are times when a placebo is used to accomplish something that has nothing to do with the efficacy of the drug. Well, it does, but it has to do with producing a change in and of itself. That is, the placebo is an effective therapeutic agent. And so we can study it that way. It's not magic. It is subject to experimental analysis. But that's not the same study as a randomized clinical trial that's done in order to determine whether or not this drug can be marketed even.
But isn't that kind of what the study you described gets at? What are you trying to find out as being efficacious? Is it warm and cuddly communication? Is it just the thought that somebody's getting an intervention? Or is it just the thought that somebody's taking care of them? So you're looking at three different things, if I understood you correctly, and you're trying to find out if any of them is efficacious. And it sounds like the most efficacious thing is good communication.
In that study, well, it added on, but the placebo acupuncture itself,
It helped.
had a big boost, right? But would the effective communication without the placebo acupuncture have produced the best outcome? We don't know.
Well, the problem that you get from clinicians, who don't live in the fuzzy world of empathy, in the intensive care unit, is that they know that if you give a patient with pneumococcal pneumonia penicillin, that patient's going to get better whether they're awake or in a coma. For the most part, those are the types of magical bullets that they're looking for. Unfortunately, many of the medications or many of the interventions that we have just are not that good or that clear-cut, in which case all of these other factors become much more critical in the mix.
Can I add to the study that I was talking about one other interesting finding, which is that the effect of the different groups was, have a certain effect size. But we also looked at the individual practitioners who were trained to do the same thing, at least in theory, in the different groups. They were trained pretty carefully to do the same kind of intervention, and the effect of the practitioner in the different groups was as large as the effect of the experimental manipulation. In other words, the different practitioners, just had different outcomes. And it was even more complicated. Some practitioners were better in the augmented outcome than other ones, and then in the other conditions, the limited conditions, different ones were better. And we videotaped all these, and we looked at them, and we were actually unable so far to figure out exactly what it is. And yet another factor that seems very important here, something about individual healers. Some seem to be better. I know I believe this is true in the antidepressant trial literature, that there is some evidence that some of the individual treaters have better outcomes than others. I'm thinking of the treatment of the collaborative therapy for depression treatment. I think there's some evidence.
Right. There certainly is evidence of that, and but trying to unpack that,
right.
And to both from because we're curious about it, but also to exploit it, to train our doctors better.
To do that.
So that they do the things that effective doctors do. These are very difficult things to track down, and then, moreover, difficult to train when we think we know them.
I'm sorry. It goes so well with what you were saying. If you think about different kinds of clinicians and the placebo effect, think about the surgeon who says, you need a liver transplant and I'm going to take out your liver. They have to convey to their patients such a tremendous confidence in what they're doing that you'd have to expect a huge placebo effect when you're dealing with the surgeons, and maybe, I don't know, the psychiatrist may have less of that conviction.
Unfortunately, the medical training system doesn't necessarily select for those individuals.
The surgeons at my institution are fond of saying, I may be wrong, but I'm never uncertain.
In my experience, surgeons are not the greatest problem. In fact, most of the psychiatric consultations are requested by surgeons, not by the medical
Oh,
practitioner.
I wasn't saying they were a problem.
Well, I'm just saying, I think they're actually far more attuned in some ways than at least some of us in medicine give them credit for. But I think part of the problem in medical training is, we select people for their skills, their cognitive skills, their ability to, get good grades in college, and we don't necessarily, see whether or not they have much in the way of empathic potential.
Worse, I think there's pretty good, I'm sorry, but very quickly, there's good evidence that over time, through the training, people get less empathic, medical students and residents, probably because they're spending so much time trying to learn the techniques that they're supposed to know, that they don't necessarily see the patient in front of them. They see the disease, they see the diagnosis, the treatment, not necessarily actually who is this person.
Well, I think they don't understand, and I think this is where this area becomes, critically important. They don't understand that this interaction, the personal element of the interaction between a patient and a caregiver, is part of what's therapeutic. I think if they really understood that they were, in part, the active medication, they might look at it differently, and they don't, because it's not encouraged in our system.
I think those studies of the medical training and eroding sensitivity, they're looking at the wrong place, and therefore they come up with the wrong answers. So I'm not a great fan of Kohlberg, but if you think of who we choose for medical school, at our medical school, so we're not Harvard, but we still have over 5,000 completed applications for 140 slots. So the people we choose are the creme de la creme, and they're used to being at the very top, and when they come in, by definition, half of them are below average, given the class. So they're very uncomfortable. And now they're starting to learn to take on a whole new persona, being a doctor, with, I contend, different ethics and different behavior required, and it's a whole learning process. So they go through these kinds of being selfish little beasts to wanting to be one of the club, and if you test them then at the end of fourth year of medical school or internship, you're going to find what looks like an erosion of moral ability, but by the time they're chief residents, they look pretty good. So I think it's a whole learning process, and I would complain about those studies.
Yeah. I was going to ask, based on something that you said, if you have a condition, a medical condition, where the cause is very clearly known, and when there is a very specific treatment for that cause, then the whole issue of placebo does not work, does not come in. In other words, if you have pneumonia with pneumococcus infection, you can be as cuddly and kind and hold the person for 36 hours. It's not going to get better. So when there is a specific cause, so where does then the placebo come in? It comes in where either the treatment is not very specific or the diagnosis is not very specific. So when it comes to depression, for example, what is causing the depression? What is it about? What is it we are addressing when we give the antidepressant is not very specific. We don't exactly know. So that in a way there is, you could generalize and say when there is no very clear-cut condition for which there's a very clear-cut treatment, a lot of non-specific factors seem to help.
I think you're right in a way, but I think there's also pretty good evidence that even with treatments that are effective, treatments for pain, that the way in which that treatment is delivered to the patient makes a difference in the level of pain relief that they achieve.
Well,
it's
that's
independent
true.
Of,
That's true. But that doesn't, in other words, if you have an effective treatment, to add the cosmetics may improve it.
Yeah.
But if you don't have an effective treatment, if you have very severe pain, just cuddliness is not going to help you.
I wouldn't say
I
that.
disagree.
And pain is a strange. Pain is
subjective.
strange. Yeah.
Pain is subjective. There's no way of quantitating it, and I think all of these so-called non-specific factors can be helpful. In fact, they're probably what's most helpful in those situations. But what I was saying is that there are conditions. If I take you to the operating room and I put you to sleep with anesthesia, it really doesn't matter what my bedside manner is. You're going to go to sleep. And this is true for certain medications that we have. They're highly active, they're highly effective, and this is the magic bullet that I think medical scientists are always looking for. They're trying to sort out these so-called unnecessary placebo effects so they can get to something that they can give and is not affected by anything else. Unfortunately, that's not the case for the vast majority of interventions that we have, and so they need to be considered.
Even if you have an effective treatment, there are some studies that show that if you do not know you're receiving the medication, it doesn't work.
Yeah, but I know those studies, but it's not.
It does.
Yeah, I'm saying if I can put you to sleep without you knowing it.
Yes, yes. But I can inject a drug that if you don't know it's being infused in you, it will not have the effect that supposedly it unconditionally produces.
Yeah.
You mean an infection, you inject, you give penicillin, and you don't say it's penicillin?
No. I have to be qualify that the drugs that were tested work that way. I don't know whether the same would be true for penicillin. But to the extent that any stimulus operates through the central nervous system and not on a target organ, then it's going to be subject to these variables.
Well, yeah, you would expect that any application in which you'd find a placebo effect, you would, at first order, expect that effect to occur with the medication as well, right? Yes. So that it may not work so simply and in this way, but it would be additive, so that the condition you're talking about is someone who's not getting the placebo effect, but is getting only the drug, and so they're missing out on a piece of the full treatment. And of course, again, why have we even come up with why do we engage in giving people placebo treatments now? It almost always is so that we can isolate the additive benefit of the medication on top of. And you're talking about the unusual case in which we've actually subtracted the placebo.
It's amusing. They sometimes refer to this as placebo studies without a placebo.
Right.
Well, it also raises the question of so-called active placebos, which has come up in the antidepressant placebo literature, and that is if you give a medication that has some sort of physiological effect, so that you're aware that something is taking place in your body, even if it's not targeting your depression per se, there's evidence to suggest that that's going to produce a more potent response in treating depression, because you're under the impression that you're being treated with something, as opposed to, as you said before, if you don't know what you're getting. This way you think you're getting something, you don't know why.
Right, so you're engaging some parts of the mind to come along and help with the expectations, and because there is evidence that there's something going on. And that reminds me of the flip side of this, which is that it's not often talked about or thought about with placebo-controlled treatments. But of course, the patients who are getting even the active medication, if they were paying attention when they were signing the consent form, can be aware that they may well not be getting anything at the moment. And it's a testament to the hope that most people have when they enter into treatment or enter into treatment trials, that it's as if they throw that out the window. And are affected by the medication as they would if they were simply being given the medication, plus the placebo effect that comes for free. And then the placebo group is, again, you might imagine that they could be skeptical and be saying, gee, I don't know that I'm getting anything at all. But most of the evidence would suggest that this is something that's ignored or set aside, and which leads to people benefiting in the way that we know that they do in many applications from placebo.
You want to say something?
I was just thinking about what you're speaking about really is what I think about as blinding essentially too, that in a randomized trial, the groups are supposed to be have equal faith that they might be having the real medication. That's what we tell them. You have a 50-50 chance. But the issue of side effects is a big problem, that if the active drug has identifiable side effects, and they're usually told what those would be as well, that they can be unblinded. And conversely, the placebo group might become unblinded and say, maybe I'm really on the placebo, as you were saying, being skeptical. I mean, I think a lot more attention should be paid to that, to look at people's beliefs about what they think they're actually getting, because you would expect that the group whether you have the drug or the placebo, if you have a lot of side effects and you think and you believe strongly that you're getting the real medication, that you should get better outcomes.
Right.
Shall we yeah.
Yeah, so we open it up. Everyone's
You have
been
to go here.
yes.
You have to
Okay.
only speak on the other one. Yeah, go ahead.
I just have one question, which is, what
thank you
happens
very
to the
much.
placebo effect if it works? That is, there's some alleviation of symptoms, and then the patient is told. Has that been checked out, I assume, in that?
The patient's been told.
I can.
Debrief.
Yes,
however you
indeed,
put it.
indeed.
I know you could speak maybe better to this in some ways, and I'm not sure that they're always told one way or the other, but I know in some trials that we have done where we have debriefed patients, patients often don't believe that if they got better on the placebo, they don't believe that they got the placebo. They say, I think you must have made a mistake or something, so they find a hard time to believe that. Oftentimes at the end of the trial, they're offered, if you got the placebo, you can now get the genuine treatment because you lost out, but the patient will say, well, I was fine. And they don't believe that they got it. But in principle anyway, I think you would expect, if to the degree they believed you that it was all a placebo effect, that might make them do worse, I would imagine.
Or lead to a distrust of doctoring.
Well, that's a huge problem, right? I mean, I think that's one of the biggest problems.
There's another side to this that we ran into with our Human Investigations Committee. We were going to debrief patients after the study was over. They wanted the patients debriefed after their participation was over. If we did that, and we had been able to maintain them on 50% of the drug they've been getting before, then by debriefing them, we were sending them back to twice as much drug as they needed. But insurance company's not going to pay for a half dose of drug. And I lost that battle.
How do you do that? Okay.
I'm curious, what if you guys aren't actually talking about the real placebo effect, but you're only pretending to, and in the next room there's another roundtable that's really talking about it? Seriously, I vaguely recall that 5 or 10 years ago there was a study by, I think, 2 Danes, a meta-analysis which purported to more or less debunk the legitimacy or existence of the placebo effect, at least to some extent. I think I've also heard that the provenance of the placebo effect is sourced from a single non-peer-reviewed paper in the 1950s and later became gospel, and because it is difficult to study on a controlled basis. How confident are we that the placebo effect actually exists in a meaningful way?
I think if you ask clinicians who treat patients, virtually all of them will tell you there are placebo effects. And so from the world of anecdote, I think there's very little question from most clinicians that placebo effects occur. When you speak to epidemiologists, you get a different level of resistance. The meta-analysis that you're referring to, which is referred to frequently in this field, did come out in the 1990s, and it suggested that there were indeed placebo responses, but they were primarily, again, in areas like pain control, in those areas of subjectivity, and that when one was looking for real objective findings, there was very little evidence for an effective placebo response. The problems with the study, like in many studies, are substantial. The major one being with the nature of meta-analyses, and I don't want to bore this group with what's involved in that. But meta-analysis is a form of looking at a whole variety of different studies and seeing from the results of those studies whether or not one can glean a directionality towards what's actually going on. They're only good, or at least they're only particularly accurate, if the results of these studies are pretty much in a reasonable similar direction. If you get results which are all over the place, you really can't do an effective meta-analysis. The other point that was raised was the one that you raised before, which is if you go into a randomized controlled study and you're told you're either going to be in the treatment arm or the placebo arm, well, 50% of the chance is that you're not going to get a placebo, that you are going to get a placebo and not an effective treatment. As opposed to in the real world, where someone gets a placebo, doesn't know it, and so they think 100% of the time they're getting effective drugs. So there are many things that complicate the interpretation of the trial, but I think the point's well taken. There are many things, including natural history, including things called regression to the mean. There are many elements that complicate, the real interpretation of what is a true placebo response. So I don't know that I can give you a very clear answer, except to say I think they occur. I'm pretty certain that they do, but it's very hard to really pin it down.
I think that's one of the worst studies that's ever been published.
Yeah.
It's fatally flawed in terms of not even the statistics, although there's some problems there. But what they did was they took all these studies, they lumped together virtually every disease that they could find. The implicit assumption, obviously, is that the placebo is going to work just as well in one as another. When they had enough studies in pain, there was a clear placebo effect. For the others, there was only one study on this or two studies on that, etc. There's no grounds whatsoever for lumping those together.
Just one other quick comment, which is, despite the problems, and I agree with what the other speakers have said, it was, I think, a useful sort of corrective, because it really pointed to this idea of a placebo for the placebo. In other words, we've got to see, is the placebo more than things like natural history, regression to the mean, just what's going on? And the trial that I mentioned, the three-group trial in IBS, was designed specifically to sort of counter that meta-analysis, and showed pretty clearly that we had two kinds of placebos that exceeded the natural history. So at least in IBS, at least for the measures that we used, I think there's little doubt that there's a placebo effect there that's beyond natural history and regression to the mean. And their point wasn't that there isn't a placebo effect, that people don't get better. It's that maybe it's just natural history and is no better than natural history regression to the mean.
The other thing, and I mentioned this in the book that I wrote, that there are diseases where placebo responses are very small in control trials. I mean, we're used to seeing high placebo responses in anxiety and depression, but if you look at a placebo response trial in OCD, very low. So there are probably certain disorders that also are incapable of mounting placebo responses. I mean, it's a whole area of study here that's not been addressed.
Right, and again, it suggests mechanisms that would be that could account for it. But again, yes. And I just don't think that there's been as focused an effort on detailing those mechanisms. Yeah. Is it this way? Sorry.
Yeah.
Yes. Well.
Maybe I could contribute something that might be helpful. I've done clinical research for 40 years, placebo-controlled studies. In the beginning, did studies with electroencephalography. We looked at drug effects on the electroencephalogram. And because we had a number of studies, what I had an opportunity to look at was comparing the first session effect, and we did Latin square designs using baseline as a control and then giving a drug and then looking at the effects afterwards. And in the Latin square, we always had a placebo included. But what we started out with is we always had a first session, which we gave placebo and discounted it. We didn't use it in studies. So ultimately, what I decided to do after many years of doing this kind of work was to take a look at the familiarization session, we called it, and that placebo response there to the placebo response in the Latin square, so it would be later. And lo and behold, found that there was a difference between the familiarization placebo session response and the placebo response that occurred during the Latin square design. So I bring that up kind of as a follow-up to your notion about, well, what's a control for placebo, which is always the problem. And we have to understand, I think, that the body is always changing, so you're always going to find something. So whether you call that placebo, if you mean by placebo whatever the normal change is, absent and the intervention of placebo, well, then that's what you're talking about. But with regard to the point you were making, I think you have to make a distinction between and you have to look at the etiology of an illness. If you have an illness that has an etiology where there's no question about what it is, like pneumococcal pneumonia, then there's no placebo involvement, and there's no placebo involvement. That is, there's no other variable that's affecting the response because you know what the etiology is, whereas when you talk about an intervention for a brain-related illness, then you don't know what the etiology is. So you're really talking about all of the other factors that may play a role other than the intervention that you may be doing, whether it's a therapeutic conversation or whether it's a drug-related intervention. Since you don't know the etiology, you have to take into account all of the other variables that play a role in the response,
Well, no, I understand.
which is
My
different
question
from
was it
pneumonia.
then was placebo just the fact that we don't know the etiology and we don't have the precise treatment?
Yes, exactly. And that combination is where the problem is, when you don't know both.
Well, I'm not sure that, it's like Dr. Ader said, the drug does what the drug does. The placebo response does what the placebo response is going to do as well. It may not be necessary for the therapeutic outcome, but it's going to occur just by virtue of the elements that are involved in its induction.
Yeah, I was wondering, is the placebo effect stronger or weaker in different groups of people? For instance, religious people versus atheists, or children versus adults, or men versus women, or even people who study the placebo effect versus people who don't?
I think that's a really great question, and I do think that I don't know that we know this yet, but my suspicion is it's about the match in some way. The treatment that we give people, for example, in that study, keep coming back to this, but that acupuncture study, some people in the limited condition, which we thought of as being not very empathic, found this really soothing, that there was not much interaction. They said, because we asked them subjectively, and they'd say, the therapist seemed so sort of, intent on on whatever they were doing. And other people said, this was terrible, they're not talking to me, And so what is it that the person wants from this particular treatment and treater? So I would expect that it would vary. And I think there's been a search for a while of, what is the placebo responder like? What characteristics might they have? And I think that's going to be, kind of a fruitless search. It depends on the kind of placebo.
Well, I think
so
the Shapiros who worked on this for years actually came to the conclusion, and I think it's the right conclusion, that there is no phenotype for a placebo responder. And one of the things that makes placebo responses so difficult and I think so unpopular amongst scientists is that they have a great degree of unpredictability. So the same person, this has been studied, the same person who may respond to a placebo in week 1 may not respond to the placebo in week 2. And this is why I think it may speak to, again, this nonlinear dynamic sort of response where the initial conditions probably are very important in determining what the actual response is going to be.
If it's established that the placebo effect is based on the expectations, if someone has had bad medical experience or has been treated with a medication that didn't do what it was supposed to, or actually harmed them, they were burned, and then they're given a placebo, it'll have negative effects, probably. It'll be a negative placebo effect. And will that be seen if they're given a real treatment? A real treatment, if they expect it not to work or to work harmfully, that would have some negative effect. Or if they're given water or a saline injection and it's told it's poison, will it have effects at all? will it have negative effects? How far will it go? Obviously, they won't die, probably. But they'll have some negative effects from this. And that's probably seen in how you're saying the side effects of drugs. That they show the negative side effects of drugs, they're told will have a positive effect as well.
There was a very interesting Japanese study done where there's some kind of plant that is like poison ivy for us, and I guess there's two versions of it, one which really is poisonous and one which is not. And they placed this plant, and they've had a bunch of people who were volunteers who agreed to have this poison ivy put on themselves. And they told them different things. I don't know how they got this by the IRB, but they told them in one case, well, this is the poison ivy, but it really wasn't. Japanese form of poison ivy. And amazingly, this is a very small trial, but people got some reaction happening here. My presumption, I'm allergic to poison ivy. When I work in my yard, afterwards I start thinking, did I touch it or not? Did I get it off soon enough? And you see something and you might start rubbing at it. I could create maybe some kind of reaction. Maybe not as bad as a really terrible reaction that you might get.
So
but
they
it does seem like...
So they may have displayed a psychological reaction, like they may have felt they were itching and scratched. But was there any biological? Was there actually redness?
Well, they had a lesion. Yeah, they had some kind of eruption. I don't know how extreme, but something that seemed. Yeah.
Thank you.
I mean, I don't know how we're ever going to get beyond this issue of the language between mind-body dichotomies. It just never ends. But the fact of the matter is, psychological is biological, and you've got one of the world's experts sitting here to tell you about it.
Thank you.
I guess my question is along these lines. When you speak of the placebo response, and you speak in terms of relief of disease, relief of suffering, very subjective sorts of things, but clearly there are somatic occurrences that are explained psychologically, something, for instance, like pseudocyesis, where you'd have somebody develop a physical suggestion of pregnancy. I had the occasion to have a discussion with epidemiologist, Dr. Friedewald, who just recently published several articles in New England Journal of Medicine, and he swore that in some of his studies in the placebo group, there were several people that developed gynecomastia in the placebo-related group. And I just wonder what occurrence of sort of physical symptoms you might see as a result of placebo stimulus. For instance, one could imagine in immunologic studies, one might suggest immunosuppression. Is there evidence that people looked at suppression of immune indices, for instance? There must be a whole variety of objective physical parameters that one could investigate, and how hard have the investigations or measurements been of such parameters?
Well, it's clearly it's possible to condition changes in the immune system. You can condition suppression of the immune system, and you can condition enhancement of the immune system. And this has been done with mostly drugs, or using as an unconditioned stimulus an antibody itself. This fits with and generated actually the whole notion of setting up a therapeutic regimen that capitalizes on conditioning. But those studies in themselves do not directly relate to placebo, unless you want to call a conditioned stimulus a placebo. They got a conditioned stimulus or placebo, and then their response was suppressed or enhanced, depending upon other conditions in the experiment. So what good is this, that you can condition this? So there's a strain of mice that are genetically predisposed to develop a lupus-like disease. And treatment of these animals is with low doses of immunosuppressive drugs, like it would be in humans. And here, a suppression of the immune system is in the biologic interests of the organism. When we treat these animals and capitalize on the conditioned pharmacotherapeutic effects that we inferred were going on, we delayed the onset of disease in these animals. And from there, we went to, okay, there's some heuristic value in looking at therapeutic regimens as conditioning paradigms. But that's the chain of events that occurred. You can condition immune changes, but that's not a placebo effect as such, really.
But at the same time, you would expect that you might find such effects.
Yes.
Using a placebo.
Yes.
Certainly. Yeah, and in the areas that I'm most familiar with, we haven't looked at what you might refer to as objective indicators. That is something that someone in the lab could look at without the patient looking over the shoulder. I mean, that's I think what you're asking about. Since we know that the placebos can induce, if you will, reports of headaches, dry mouth, and all manner of things that aren't expected to come from the placebo pill itself. But you're asking about the further conditioning of these effects. Yeah.
In fact, one of the important aspects of seeing these negative responses under the placebo arm of a trial is people who are conducting the trial can get a better idea of what the actual side effects are for the drug, because they can begin to sort those two camps out.
How easy is it to induce the symptom of sweating in placebo work? As you notice?
People will report this, and I think what you're asking about is measured sweating, and I don't know.
Either way, sweating. I mean, are people would the people be particularly prone if medication were to cause hot sweats, for instance?
Well, sweatings are, basically mediated by the autonomic nervous system, which is very sensitive, we know, to a whole variety of psychological
including suggestion.
input.
Yeah,
including
sure.
suggestion.
Yeah. Mm-hmm.
I just want to thank you for having this discussion, because it's been great and it's been a topic that I've been interested in for a very long time. I see parallels to going of the placebo effect back to the medicine man and the tribal doctor, and it having to do with belief in their powers of healing. And so I want to ask a question looking forward. Is there a way to reframe the placebo effect as sort of learned wellness? And towards that end, wouldn't the existing power structures, the drug companies and so on, be resistant or certainly not have no reason to fund that sort of research?
I think that the drug companies would be interested in understanding the placebo effect for the purpose of trying to reduce it, so that they have more chance of showing their drug to be, and so they might find research that it involves understanding the placebo effect that we could then use, they could use for their purposes, and others could use, hopefully, in a more beneficial way.
I've given talks at pharmaceutical companies, and they have no problem with what I say. You go back to the chief's office, puts on his company hat, and says, you won't get a dime to do this research.
How can we change that?
Well, actually, if I'm right, it's going to cause a lot of trouble for the drug industry. On the other hand, I think that while their first response may be find out what's wrong with this, I think they may think better of that and saying, maybe there isn't anything wrong with it. We'd better get on the bandwagon before they really mess up things. For example, drug companies frequently use a design where they will wash out the drug and then come back and give them the same drug or a different drug or what have you. Well, you can wash out the drug, but you can't wash out conditioning. So they think they're coming back with a tabula rasa. They got a naive patient. They do not have a naive patient. That patient is already conditioned. That's going to cost, I don't know how much to change, but I think that in the long run, they can build a safer therapeutic agent by capitalizing on this than by fighting this. In 20, 30, 40 years from now, it may be possible for a prescription to be written with, this is the drug, this is the dose, this is the route, this is the frequency, this is the duration, and this is the reinforcement schedule. And the pharmacist knows what the reinforcement schedule means. So he fills this bottle of 100 pills, except that only 80 are real. It's impossible for the patient to escape that schedule. So whether you take your medication or don't, and most people don't, at least for a good portion of the time, you still can't escape the schedule. So I think there are a lot of repercussions for the drug industry, but I have a great deal of faith in them. They'll figure out a way to make money out of this, no matter what you do.
Well, you know, my concern isn't so much for the pharmaceutical industry because, as you said, their main goal is to make money, and they'll figure it out.
Yeah.
My question is how clinicians and medical scientists can look at these placebo-controlled trials, see response rates, you know, regularly at the level of 30% up to 60% in some, and continue to ignore the fact that this is occurring, as though it's just some noise in the system.
Well, it'll get worse because theoretically, in the system I'm talking about, it will not be 30% who respond, which, by the way, is a euphemism for 0 to 100.
Right.
But 100% of the people will respond. It may take some people 5 trials and some people 50 trials, but 100% of the people will respond. I mean, it's just straight conditioning. I mean, they're going to learn it no matter what you do.
That's true, but where is the incentive coming from the NIH to, you know, put together large amounts of money to study the placebo response?
There isn't.
Exactly. You know, they have an occasional RFA once every 25 years.
Right.
This is a question about conditioning to the effect of the drug. This is a real case. A friend's daughter was being thrown out of the school for holy terror, you know, climbing the walls. It was ADHD. She was put on Ritalin, and you saw dramatic change. The school was no longer in trouble, bothering her with her. The therapeutic effect continued for something like 3 months, and then the behavior returned. So my friend went crazy, what's going on? It turns out that a generic drug had been substituted, and more than one parent had noticed the change in behavior of the kids. So my question really is, if there's a conditioned therapeutic effect, it should have handled those kids. But if, you know, as you say, if this drug were a magic bullet, then it would not, because it wasn't going to provide some kind of placebo effect.
Well, I'm not sure I completely understand the question, but I don't think you can maintain patients just on placebo. Mm-hmm. If you're going to adopt this strategy, you're still going to have some reinforcement schedule. Now, depending upon the situation, that can be as low as 15%, maybe even lower. In terms of literature, but that's with different drugs, that's with different people, that's with animals. But you won't be able to maintain it indefinitely. And I imagine that would change depending on what the condition was.
So your suggestion would be that had it, instead of a switch from the regular drug to a generic, which had different properties apparently, it was a switch to 50-50. Generic and the old drug, that might have persisted even though the generic one on its own wouldn't be of use.
Yeah.
One other thought, which is not about conditioning per se, is that we often presume that if someone responds or doesn't respond, that it's necessarily that it was the drug that did it. It's possible, I don't know what this circumstance, but you know, that in some circumstances people would have gotten better no matter what you gave them, and would have gotten worse no matter what you did. In other words, this drug might not do anything for this particular person, and they you know,
or the persistence of that drug might not have maintained itself.
Sure. But I mean, I'm just saying other circumstances in the person's
right,
life.
Yes.
You know, something really bad's happening that no one's aware of, that's making this kid act out more. That's another factor. All I'm saying is that there are many, many factors besides the drug itself, which may or may not be effective.
Right. In this case, they restored the original supplier, and all the kids with problems went back to theirs.
Yeah, in reviewing some of the literature, ADHD ADHD is another one of those disorders where the placebo response rate is not quite as clearly high as it is for depression and anxiety. It's not as low as OCD, but it's not high.
Right.
Hi, thank you so much for this. First, I'm really excited that the conversation came back to immunity. I just want to say that I think since stress and immunity are so tied together in natural killer cell activity, that would say to me, I think it would say that even surgery, even pneumonia, where we say that is an example of a magic bullet. In fact, many surgeons report that the disposition of a patient going into surgery for sure relates to outcomes. So to be transparent, I worked in PNI at Sinai on studies looking at response expectancy around the time of breast cancer diagnosis, before and after surgery. Now I am in the field of narrative medicine, which started at Columbia Medical School. And I'm curious, since there are so many factors in placebo, is the doctor trusted? Does the patient have a different sense of agency by putting a pill in their mouth? Did they spend enough money on the pill to have the stakes high enough that they need it to work now? Where I think the drug companies might actually benefit from the fact that if it's free,
They already do.
if it's free, and we know this with education too, and we know this with therapy, I think. When we pay for it, it works better, and when it's free, it doesn't work as well. So I guess in narrative medicine, we believe that the narrative, the hidden narrative the patient comes in with, their assumptions, their life story, and the physician's narrative very much affect what will happen. So I wonder who's doing research so far on actually eliciting those narratives in order to see if there's a relation, to really break down response expectancy, I guess. Are there groups doing that? And if so, are those studies of narrative considered in the field of science and medicine, or are they considered outside of it and purely in the social sciences?
I think it's a fascinating question. I think one of the things that's very clear to me is that the more you know about the history of your patient coming in, the more you're going to be able to be helpful, and perhaps even the more you might be able to predict whether they're likely to have something in the direction of placebo or nocebo responses. I don't know of anybody who's doing actual studies on narrative scripts and looking at that, but it's a very interesting question.
But you do have instances where people pay a lot out of pocket. I'm thinking assisted reproductive technologies, and the response rate, successful pregnancies, is 20%. So you have real instances of high expectation, believing in the therapy, putting your money on the table, and it's just, does the treatment work and how well? And so I don't think that supports narrative.
Oh, I think in the case of fertility, the belief, where the belief has to be, may not be in the drug or the doctor, but may need to be, that I think would be tied to sort of the narratives coming in, or the belief in the relationship, or the belief in the money to raise the kid. And, I think you're right that belief in a drug probably wouldn't be sufficient with certain things and in certain cases. That's why I think there's so many factors with the placebo effect. I think it's so complex, and I wish there was a field of study, and I do think that there are people who would fund it because the stakes are so high, and the drug companies benefit either way, I think. Because people are still going to buy the pills. We just need to understand. I think we need to understand it better.
I'll just read one quick thing. So, in the study that I described, one of the components of what the therapists were supposed to do in the enhanced part of the treatment for IBS was talk with the patient about what is the meaning of the illness, how do they understand it. I don't think it's really getting at what you're asking, and it certainly wasn't it was just a component. We kind of put in the whole kitchen sink and everything we could think of that might be active. Other studies would be to try to unpack that in some way. What part of this is important, So do you have to have that, or is it just enough to have a warm and empathic relationship? Do you need the narrative or not? I don't know. We included something along what you're talking about at least about what the meaning of the disease was for the person, even about metaphorically, how they thought about the disease metaphorically. What is this for?
Have those been analyzed yet?
Well, no. Okay.
I have two questions. One along a very simple question is, how effective is this effect? Like, what's your range? And I heard you say 30 to 60, and I'm sure the complexity with the constituent, with all the variables would vary. That's my first question. My second question is going back for the 1,300 years of Asclepian medicine from 1000 BC to 300 AD, in which Placebo and Hygiena, the two daughters of Asclepius, were believed to give you the dream and the cure. And where has that gone? Is there any resurgency of that whole domain of medicine? So those are my two questions. Percentage
I can
and
give
Asclepian.
I'd say something about the first question. So, yeah, I think what Richard was referring to was the probably the highest placebo response rate, which you'll find in antidepressant trials. Well, I think in antidepressant trials you'll find the highest placebo response rate, and those, depending on criteria, et cetera, would range between 30 to 45%. Now, that includes, though, the passage of time. That includes what would have happened had no placebo been given. So what we're interested here is what that extra bit is. And I know there were some older studies that were similar to the one that you described for IBS, where those kinds of things were isolated. So they're a waiting list control group versus the placebo group, where these mechanisms might be generated. And maybe someone has a clearer memory of those than I do. But my recollection is that the placebo would have been about half of that response, and the other half comes from just the passage of time, regression to the mean, people getting better for various other reasons. So there's still a pretty sizable chunk, again, in depression as the most extreme, and then it cuts back from there for the disorders I know about. And then
I would agree with that in terms of the daughters of Asclepius. I think we're certainly not in the world of the university or academic medicine are we moving in that direction. There are always people who are working in the alternative complementary world, who are interested in incubation and dreams and that type of approach. But I think, once Hippocrates moved away from the Asclepian model, and he did, he was still an Asclepian, but he moved away from it. I don't think we're going back, in the very near future.
Environment. Go to the temple, get away, get good massage, get good air, good food, no more stress.
Well, we have it in the
sex,
form of spas.
Hey, you start feeling better.
We have it in the form of spas, and that's what
people use them that way,
yes.
don't they? Yeah. Mm-hmm. Not just for pleasure per se, but for restoration.
Actually, that's a good introduction. No, I'm a hypnotist. But in the hypnosis community, it's widely accepted that a placebo is a form of hypnosis because you're giving someone a suggestion that this may work. So an interesting study would be to have a bunch of doctors or a bunch of people dressed as doctors, because I'm not a doctor, I play one on TV, right? to wear the stethoscope and say, listen, I'm not supposed to tell you this, but this is the drug. And this is the new enhanced version. And it's very, very expensive. So be really careful, don't drop it, and see what kind of effect that would have. I would agree with a comment before that it's almost impossible to remove the blind. I mean, to have the blind there, because either consciously or subconsciously, we are perceiving that there is a change in the body from whatever drug that we're taking. And when there's a placebo, there is apparently no change in the body. So unless you can trigger some kind of change in the body that is, okay, I'm actually getting a drug, now I know it's going to work, okay, that has to be filtered out. Now, a way to enhance the placebo effect, not only by that indirect suggestion, but actually going into the mind of the people receiving the drugs and saying, where are you mentally right now? And here's some new belief systems. Hypnotists can install belief systems into people's minds that would allow them, the structure, if you will, to start building a healthy mind-body. Because for some people who are into alternative medicine, they believe the body's out of sync in some way. And by taking a placebo, by taking a drug, by going to a doctor, even visiting with a doctor, you're saying, well, now someone's paying attention to me. Now I can be back in sync. Or now I'm taking a drug and I can be back in sync. Or something else happens. So but the final comment I have is that, you're talking about training doctors to kind of create that belief system in someone. Well, that's not really their job. And in fact, telling a patient that you're going to do really well in this operation could be grounds for all kinds of problems, the lawyer tax, right? So if you want to avoid the lawyer tax, have someone else do that, okay?
Someone who is not in. Exactly. Not under any.
Not a doctor, but someone who's going to say. Placebo doctor. Yeah, placebo doctor. Someone who's going to come in and say, by the way, this doctor, he has to say these things. That's the rules of malpractice, etc. That these things could happen. But let me tell you, this is one of the best doctors you've ever had. And here are some of the things your body is going to learn, and how your body is going to change when these things are applied to you. If you tell a patient what's going to happen to them, okay, even by just walking along, hey, when you walk, your body is going to be more healthy. Okay, this glass of water has been blessed by some kind of superpower, and when you drink this water, you're going to feel so much better.
It'd be interesting to be a challenge, though,
exactly.
To write the ethics codes for that profession.
Well, that is the challenge, but many nurses out there do that every day anyway. Some of them do, some of them don't. Say, oh, that's a good doctor, and you're going to feel great.
Doctor or not.
Right.
Exactly.
One imagines it's not disingenuous, though, right?
Yeah.
I mean, that's the real problem. Right?
Yeah.
And I think there's still doctors who do that themselves.
Of course there are, but like you said, the filter, the selection process of getting a doctor who's technically amazing, and a doctor who understands that creating a belief system in a patient that they're going to go into this operation and you're going to just relax and let the instruments do their work and accept that change in your body and allow it to be a benefit. That language is something doctors simply don't know at this point, of how to simply use, like Milton Erickson, use some very simple language to allow that belief to be created in the person's subconscious mind, and the brain actually then opens little channels of possibility to allow something that's blocked in their body to start processing forward. Someone mentioned something about breast cancer operations. There was a study done not too long ago where hypnosis was given on a CD, and there was less bleeding. This is a clinical study. There was less bleeding, much less pain, and faster recovery. Mm-hmm. So that's just one small, if we could reduce the time of an operation by 8 minutes, that just, the healthcare world would really take note of that. And that, by the way, is where we can get our dollars from. The healthcare industry needs better, more effective treatments without spending big bucks in the pharmaceuticals. So it's not the pharmaceutical companies that are going to drive it. It's driving down the price of healthcare by allowing people to engage in the belief process of that they're going to get better because they're taking these drugs, and then prices can come down and the drugs can be less severe. Thank you very much.
Thank you.
I wanted to get back a little bit to medical education. I was very struck by your comment that students and residents don't understand that they are the active agent.
Come a bit closer.
Sorry, and I think that is a very important point, that we really need to just kind of reframe the placebo effect as a positive effect, because now I think that students and residents, they feel rather cheated if they find out there's a placebo effect. Mm-hmm. They're like, oh, did you see that? How could they get better in 10 minutes? Obviously, that's a placebo effect. And they feel very cheated, like somehow something's been lost. And it's right, they don't think, I did that. And they don't see that I think if we could reframe that in their training to know, that time you spent talking to the patient or hearing their narrative, that is time well spent. And there is data to say that that is very effective therapy, because I think now, we are, bringing into our medical school students who do very well on, standardized tests and everything. But so they are very data driven. They like numbers. They like doing lab tests. But if they could really see that the time they spend, talking with their patients, like your study, is that it's very effective therapy, I think that's the only way to convince them to take the time, for many of them. Of course, some of us, there are people who do it naturally, and that's what they like. But there are other people who think it's not a good use of their time, and we have to reframe this placebo effect, because obviously it's very powerful.
Well, also because there is a science. And I think that's where we haven't really developed to the extent that we should have by now. There is a science to the placebo response. Many of these people coming into medical schools think of themselves as young medical scientists.
Right.
And they don't want to be dealing with something that they think is something magical or unpredictable or non-scientific. But this is a scientific response. We just haven't addressed it properly yet.
Exactly.
And we are, at Mass General, working on trying to help to train, doing some studies, can we train residents to be more empathic? And one of the ways we're trying to do this is engage the science side of things. Talk about mirror neurons in the brain, and that empathy is not some squishy thing that's not scientific. That it actually has brain correlates, as an entree to sort of pull them into this. That this is worth doing. This is a real effect. It actually has effects in the brain.
Right, exactly. But I think more and more of that needs to be done to convince all the students.
This is coming back here in the fall.
What's coming?
The mirror neuron guy is coming back.
Oh, great, yeah.
This is just a distinction between hypnosis and the placebo effect. It's a study I became aware of. People were given heroin to eliminate pain, and the control groups, one was hypnotized, the other had placebo, no painkiller, but still experienced pain relief. And in the group that got heroin, they gave the drug naloxone, which kind of like wipes the heroin out, so the pain returned, which is what you would expect. In the placebo group, getting naloxone also resulted in a restoration of the pain, which meant that the placebo patient had created an actual molecule to block pain, and you could remove that actual molecule by giving them a drug naloxone. The mystery group was the hypnosis group, because they also had pain relief, but naloxone did not remove the pain for them, which meant that the hypnosis was operating through another route. And not that it wasn't effective, it just was using another pathway.
That's really interesting. I am a medical student. I'm wondering if it's possible to separate the sort of empathetic induced aspect of the placebo response from maybe the confidence component of it. Is there a difference between the effect that results from someone taking care of you and just that relationship being established versus an effect that comes from having expectations? We sometimes tease. I have a classmate who is sort of a jerk or makes jokes that are a little inappropriate. And she says, it's okay, but I'm going to be a really smart doctor. And I'm going to have patients who would rather see me because they have confidence in my skill rather than someone who's a little more touchy-feely. And if maybe there are two responses, in fact, operating, one which is those high expectations you get from having someone who's very skilled at what they do versus just feeling like someone talked to you that day and that made you feel better.
We've discussed doing this in some of our studies where we would experimentally manipulate things so that in one case, try to foster positive expectations verbally, and maybe other ways, versus not. And then cross that with being warm and empathic versus not. So you can try anyway to begin to tease this apart. My own suspicion is that it's probably better to give both. For you to feel like this doctor cares about me, is warm and empathic, but they're really good too, and they're giving me an effective treatment. But that's something that needs to be investigated to really to know. That's something we're very interested in.
Has there been any?
Yeah, there have actually been a fair number of studies in the behavioral literature looking at the attributes and personality characteristics of caregivers and physicians. And certainly being empathic, being a good listener, spending time, those tend to correlate with better outcomes. But also competence tends to correlate with better outcomes. And almost certainly it has to do with how you've been conditioned, getting back to the narratives element. If being approached in a non-empathic way may be something you're comfortable with and you're looking for somebody who is just an expert in their field and you think is competent, that may yield a better response in that individual than another.
I agree with you completely. I think of the sort of stereotype of the extremely competent surgeon with a very poor bedside manner. You might feel like that means they're even better. Somehow that their technical expertise. I think that's true. It's what people are looking for.
And patients would differ. I mean, it's come up a couple of times, right? And you're suggesting it that some would just rather not deal with. I have friends. Thank you. My doctor's my doctor, and others would want to feel the human connection. And you'd expect. You'd expect, although I don't know the studies that have looked at it, you'd expect that would predict differentially for these patients, if you will, the placebo effect or the extra effect beyond the active ingredient.
It depends entirely upon the illness, natural course of the illness, the cause of the illness.
Personal narrative.
The answer is going to be completely different for every illness.
Okay, I think we can stop. Thank you.